啊，咁啊，咁啊，多謝。
Welcome, Permanent Secretary and his team. Let's get started. Today we are here to talk about the manpower planning. There are 3 papers made available by the administration. The first one is in response to Mrs. Regina Ip's request concerning the Australian experience. The other one is about the manpower projection. And last time I asked the administration for some data regarding the manpower. I'd like to call upon the Permanent Secretary. Right, Chairman, we're talking about the healthcare manpower planning. The papers are on follow-up issues. Right, the member is not here with us yet. She has signed up to attend the meeting. I've read the paper myself, and there is a paper on the overall manpower projection. I don't think there is anything new in that paper at all. Perhaps you might wish to briefly take us through the paper. Perhaps I might have overlooked certain things, and this is only taking stock of the situation, and I don't think there is any new in the paper. I'm referring to the manpower projection. In January 2012, we have set up this steering committee with membership from the healthcare professionals, the training institute, and the monitoring bodies, and there are 6 working groups that have been formed, or 6 committees. We have also commissioned Hong Kong U and CU to give professional input and technical support. Hong Kong U projects the healthcare demand for us, and CUHK will conduct a comparative review of the regulatory frameworks in local and overseas contexts. The members of the coordinating committee and the consultative committees looked at the challenges, the way forward. They had some discussions there, and the 2 universities also brought the committees up to date on the findings. Now, we understand all the constraints and challenges in this regard. Hong Kong U is trying to formulate a model that is in keeping with the local situation and enable us to project the manpower demand and supply in the planning horizon of the next 15 to 20 years. They are putting together a computer model. CUHK has come up with the interim findings. In relation to manpower shortage, there are many different jurisdictions that are relying on the healthcare professionals from abroad. The criteria vary from country to country. In terms of regulatory system, there is a worldwide trend towards transparency and checks and balances. In order to enhance the professional qualification, continuing professional development has become a norm. And also, the investigation and disciplinary functions in the regulatory body are increasingly being separated to avoid any conflict of interest. Going forward, the steering committee will have regard to the findings of the studies of the 2 universities and work out the way forward to make sure that the healthcare profession will be in keeping with the best practice in the world and also having regard to the unique circumstances in Hong Kong. The steering committee aims to complete the reviews within this year, and then in terms of training and healthcare professional demand and development, so on, there will be recommendations to be made. So, Chairman, this is a brief outline of the progress, and the two universities are still getting on with their studies, and we haven't got the detailed data. So this is just to give some ideas for members about the latest state of play. In the next coming few months, Hong Kong U will be able to put together the computer model, and CUHK will be submitting a more detailed report with comparison between Hong Kong and other jurisdictions in terms of the regulation and also the supply and demand of healthcare professionals. Thank you. Mr. Chen Kin-po, Chairman. I'd like to bring up the Australian model. Well, if this is the case, let me put a question first. Well, the computer model and the precise data will not become available until a couple of months from now, is that right? Yes, Chairman. They're putting together a computer model with 6 major sectors and 13 healthcare disciplines, and they will be putting together a comprehensive model. Well, you will be invited back about this. What about the time frame to start with? Well, I'd expect it within 1 or 2 months' time they will have some prototype. Now, as you understand, the development would be pretty slow at the initial stage, and they have undertaken by the middle part of this year, they would be able to run the data. Right, how soon do you want to come back to us with the further details? Yes, Chairman, we are considering this. We hope that by May or June we should be able to come back with further details. If you're interested, we can also invite the institutes to join us. Well, computers are there to help us. We program the instruction into the computer, which will work for us. The strength of computers is that it is able to compute 10 times, 100 times, or 10 million times very, very efficiently. And you do need to have a mathematical model. And we should be able to work out the details manually. Well, you said you don't have any model available overseas. Well, Chairman, let me clarify. It's not the case that there is no such model. They're doing the same thing all over the world. But there is no universal model for estimating healthcare manpower. And different places would develop their own models. As you said, Chairman, the computers are working for us. The most important thing is the assumption, the input. The world over, there is no such universal model available for us. Well, that's quite another thing altogether. If there is no universal model, there may be a couple of models available, 2, 3, and so that there would be some models available. You should tell us how many models there are and how they work in practice. Chairman, if you are interested, I can let members know about a few of them. There are so many countries in the world, but there must be some major principles that they abide by. It would be difficult to share the model between different countries. But if they do have the models, although there may be some discrepancies in terms of the details, please let us know. If you haven't got any new information for us, I don't think we can go into detail about it. Mr. Peter Chung, any questions? I'd like to seek some breakdowns regarding the different disciplines. While we'll follow up on this, we are dealing with the strategic review on healthcare manpower planning and professional development. They had the steering committee set up in 2012, and the two universities are still getting on with the studies, and they won't have the data until 2 or 3 months from now. And then we'll be talking about the manpower projection and Australian model. Well, Mr. Ship is not here with us. Perhaps you might wish to share with us the Australian experience so that Mr. Checking-Paul can follow up later on. Right? Shall we invite the administration, please? Or you don't really need to say anything at all. Chairman, this is a detailed paper put together by the research office. There are some technical terms. I think we can go straight to discussion, or if you so wish, we can invite Chris to give us a brief outline of the Australian experience. Chairman, thank you. Well, let me briefly take members through the paper. We have a lot of information in the paper. Australian and Hong Kong situations are different. Australian residents have to take part in the Medicare in Australia. Each one of them has an account for Medicare. If they need medical service, they have to source their own service, but the government will pay for it. And there are some requirements. There are prescribed fees structure for different kinds of services, and this is the same for all kinds of healthcare services. On top of that, the Australian government encourages the residents to take out a private health insurance, or PHI takeout, and this is on top of Medicare. There are more advantages. Now, there are certain things for certain treatment for which Medicare cannot cover, but this can be covered by PHI. And if they want to opt for private care or certain doctors or more expensive treatment, they are able to do so under PHI. So in Australia, there is a carrot and stick approach. By carrot, I mean, let's say if you've taken out the PHI before 30, there is a rebate for premium. It all depends on the age level. Normally, about 30% of the premium will be rebated. Now, there is also a stake element. If you take out the PHI after 30, the premium will increase year on year. The idea is to encourage people to take out an insurance earlier in their life, so they have the carrot and the stick to beat people with. Now, the way they collect the premium, they have the community-rated premium. Whatever your age, or whatever state of health you're in, there is one single flat rate. And they have all these people in different age profile and different health profile. They lump them all together in a single pool. But this is voluntary, isn't it? Each insurer, now, if I take it out, or a 60, 70-year-old takes out that insurance, there is a flat rate. It is voluntary. So they have to have the carrot and stick system. Now, under the community-rated premium, there is greater incentive for the senior citizen to take out insurance, the younger age brackets will be less incentivized to take out insurance. The idea is the earlier you buy, you take out the insurance, the better. If you leave it till later in life, there is a penalty. For those who are well off, you still have to take out the insurance. Otherwise, there is a penalty slapped on you. So the idea is to make sure that they can achieve a community rating with a high enough participation rate. They have come with all these ideas to make sure that it will run properly. There are different elements. Like they have the risk equalization. As you're aware, there are so many different insurers taking part. There are some insurers that are taking on the old and ill health people in ill health, and it will be difficult for them. So the government is trying to transfer the risks according to the level of risk. There may be some insurers that have more high-risk people who are in ill health, who are old, and there would be greater costs incurred for them. So there is a risk equalization approach. The government doesn't have to pay anything at all. The risks would be pooled between all these various insurers, and it would avoid the situation where some certain companies would be taking a predominantly large proportion of old and sick people. Perhaps I pause here. Basically, the situation in Australia is to encourage people to take out PHI, and they have the community rate premium, and they have come up with all these ideas to make sure the young people are incentivized to take out insurance as well.
Mr. Chen Kim-po, well, I'm quite concerned with the line here. You're saying that it's said here that the Australian government actively intervene in the private market. I'm quite worried about it. Australia is a different picture. I'm sure they have spent lots of years in rolling this out. Now, it seems to me they are intervening in the PHI market, which I don't think is appropriate. And do you plan to do this? Do you plan with the HPS that you're going to impose some regulations on the PHI market? The Australian government has this for many years. Well, please understand that this is going to be a voluntary scheme for the public, and you should also make it the same for the insurers. If they don't want to do something and you force them to do something, it's not right. Let's talk about Table 2. You have some figures over there. And the management expenses amounts to about 9%, and the underwriting margin 5%. I'm not sure whether is the case that people do not have to pay premium in Australia, or is it covered under the management expenses? Can you answer me now? If not, please do so after the meeting. Concerning regulation, we will learn from lesson overseas. We'll take those lessons that are working well there. We have consultants working closely with us concerning the future approach in Hong Kong to work out what's best. Well, we haven't made any decision yet. I can tell you about the planned direction or preliminary direction concerning the basic coverage. We will be very likely to take the experience from Switzerland, Australia, or the US. Say, for example, we'll provide basic coverage for members of the public so they feel rest assured about which areas are covered. Now, we know about this hot balloon tragedy in Egypt. The 9 victims were covered under by insurance policies, 3 through the travel agents. So they know what areas are covered, but that's not the case for the other 6. It just shows that you only know which areas are covered when you're in need. If we have basic coverage in the market, then members of the public will know very clear what areas are covered and which not. If they want extra coverage, they can get more broader coverage. And we do not plan to set the threshold too high. We'll look at the PHI in the market to see which areas are covered. Say, for example, 80–90% are covered. If that's the case, we will adopt that approach. But if we set the threshold too low, then we may ask them to raise it. So this is one of the way forwards we're looking at. Secondly, my colleague just now, that is Mr. Sun. Let me just have the name again. Well, he is the head of a Healthcare Planning Development Office. He mentions the community rating in Australia, and no one will be left uncovered. That's why some insurers cover those with high risk. And the government will, and people think it's not fair sometimes. That's why some insurers will be asked to take out a certain percentage from what they get. But to be honest, we do not have the resources to be so strictly fair. Still, I think the practice is good. That is, the insurers cannot leave anybody uncovered. That's why we hope we can set up an independent pool so the high-risk insured people can be included and we can have shared risk. The insurers may not be able to take the financial commitment with the high-risk people. That's why we have to set up the independent risk fund or the pool in order to set down the definition of high-risk and low-risk insured people. And if they set seed money can be run properly, then it will be a good idea. With this, the government will not have to intervene in the insurance market and tell insurers how much they should earn, how much profit they should make. Well, in terms of the practical side, it's rather complicated. And we are still working with our consultants, and I cannot give you a very detailed answer at present. But what I can tell you now is about our direction, our way forward. Now, thirdly, about the Commission. As far as I understand, I think the Australians have covered it under the management expenses. The mode of operation may be quite different from ours, but I can answer you later after we have a look at it. Chairman, several points to make. I'm very glad to see that the government is going to be rational. They're not simply copying the model. If they're simply copying from Australia, I'll ask you, how come you do not copy the model from the US, which is very free, very liberal? Now, you have to understand that Hong Kong is quite different from Australia. Hong Kong has all along been quite free. Our market has been quite free compared to Australia. My next question is, when will you come back to LegCo to tell us about the product features? When will you come back to tell us about that? So, to put it simply, a time frame or a timetable. Well, I think it was set down to be the middle of this year. Can you make it? Well, can you make it? Because you have lots of discussions are going on. April, can you make it? I don't think so. The middle of this year, maybe May or June, we will have a better model. I don't want to set everything down before we come to you. So when we have a clear direction ahead, say, for example, the basic coverage which has been discussed and agreed upon by those in the market. If we got that already, I think we will come back to listen to your views. Now, when we discuss with the trade, we'll make it clear that we're trying to give more options to members of the public in the future. And for those who can afford better doctor services, they can opt for private hospital services. So we do not propose to do anything to affect the insurance companies. We do not want to defeat them in their business. We hope there will be a bigger market for the insurance companies. And as Mr. Chen puts it, Hong Kong is very free and we are quite different from overseas. These insurance companies are international companies. They know their positions in, say, for example, Switzerland, US, Australia. And I cannot tell these companies that we are a free economy and the others not. And I can tell you, when we come back, we will tell you about the macro view. If you haven't got to a consensus or an agreement with those in the trade, please don't say so. Please don't come back to us before that. Yes, I agree with Mr. Chen, but please understand that we would like to know the position, and we try our best to come to a consensus with the trade. And if not, we will tell you our position and the views of the trade so that the subcommittee members can also throw in your views as well. Well, we planned to have a discussion on the 5th of April. In fact, we'll talk about the control and the mode of operation, the structure of the HPS in April. But if you cannot make it in April, then maybe we can delay the discussion. Otherwise, that would be a waste of time. So let's shuffle the agenda items for a bit. Now, I want to seek clarification about certain points. Mr. Sun said that in Australia, the Medicare is a voluntary scheme, but then there is a set or fixed rate for premium. It's different from what was said before. At previous meetings, members asked whether you can have a fixed premium rate and that will not increase according to one's age. You said if it's a voluntary scheme, that can't be done. If it's not voluntary, that can be done. And that's the reason you said why it's not possible in Hong Kong. But in Australia, it's a voluntary scheme, yet they have a fixed premium rate. It's just that they have other approaches to share out the risk. It means it's not about the problem does not lie in voluntary or involuntary scheme. Well, let me explain a bit here. Australia is the only case where we have this voluntary scheme. They set the fixed rate for premium for people with different health conditions. The government has done a lot in terms of research, and they've also got measures punishing those who do not take out PHI after 30. Now, the premium rate will increase, and they give incentive to young people as well. Now, for the government, you can have the scheme, the compulsory scheme for everybody. But if you want lots of people to take out insurance, PHI, the Australian government has done a lot over the years before they roll out. So they turn it into in fact, it's an involuntary scheme because they have this stick and carrot approach. As far as I understand, the premium is subject to increases. but you have to make application with the relevant authority. I think that Mr. Chan is most concerned about imposing regulations on the premium. Well, we do not want to do that as well. We try to avoid that. Well, concerning the Australian model, any further questions?
When Mrs. Yip comes back, we'll let her have the chance to put the questions again about Australia. Well, we can always come back if you have any questions to put. Right, about the manpower projection for the hospital authority, we are given all these tables with not much in the way of words. So there are 12 tables presented to us. Any questions? Mr. Peter Chung, if you don't have any question, then I'll have a go. Let me cite the A&E department, for instance, table 12. That is the last page. Here there is one way. There are 2 points, in fact. Now this is different from what you said in previous papers. Previously, CB2 2011 stroke 11 to 12 bracket 01. Appendix 1 there. Well, at that time, the projection, according to my understanding, applies to all these different disciplines. You have the table here. Basically, you have reference to the population projection for different age brackets, and also the utilization rate of services by different age brackets. And then on the basis of these utilization rates, for A&E, the number of attendees, and then you project the amount of time needed, the amount of time, and then you multiply that to work out the total amount of time, and then you divide it by C, and that is the total number of hours worked by each doctor, and that is how you extrapolate the manpower demand. I suppose you work out the manpower on the basis of this for A&E department. Now, in the paper, you have given us some information about the utilization rate. CB2 2690 bracket 11 to 12. There is a table here, table 1.4, and the number of attendees is table 3. A couple of tables in table 3, the last table. 2.7 billion in 2026. Now, here, table 12 is a completely different model altogether. Perhaps you might wish to enlighten us on. Now, you need 560 people in 2026 for the A&E department. How did you arrive at this particular figure? Well, Chairman, there are 4 sets of papers, November 11, May, and August 2012, and this one is today. Now, if you read these 4 sets of papers together, then you would get some ideas. And in table 12, in this particular paper, basically we have different progress, and we have different models for different disciplines. Now let's take a look at the manpower level for the different disciplines. Basically, we'll look at the amount of services, and then we work out the time needed for different services. We have the total, the grand total, and then we extrapolate the manpower. Then this is applicable to all the different disciplines, including the A&E departments. When we do the projection, we do have different time frame because different departments will have time to get on with the details, and like the medicine and the surgical, other disciplines are moving more slowly. Now we haven't got the detailed model for the A&E department, although it is emerging. Now for these 4 disciplines, this is really a rough estimate. Basically, we look at the services, total number of hours, and the number of patients. Perhaps I defer to Ms. Cui to take members through the projection parameter for the 4 disciplines. Chairman, Dr. Zhou has already highlighted precisely the methodology. Back in May, when we presented the paper, we said we took the projection of population to extrapolate the service demand and then the number of hours worked by the doctor, and from that we work out the demand for the number of doctors. It's just in table 12. There are 4 different disciplines. Last time the hospital authority conducted this rather complex projection modeling for the first time. Let's say the A&E department that you quoted, Mr. Chairman, we projected the service demand, and then we skipped the number of hours, and then we leaped to the projection for the number of doctors. Now we have said in table 12 that table 1.4 in the August paper, table 3, the latter part of the paper, we have projected the number of attendees at the A&E departments, and from that we extrapolate the demand for doctors going forward. But the speaker stops speaking through. Well, we come up with this large table for the different disciplines, but here with this projection model as of 2011, we haven't come to all these minute details. Well, it doesn't matter what methodology you have. Can you tell us how did you arrive at the 596? Now this table has been given to us many times. My version is in paper 2011 stroke 11 to 12 bracket 01. Table 2, you have A&E 42408 517 and then 596 in 2026. Now 596, how did you arrive at this particular figure? Well, in 2026 we need 596 A&E doctors. In 2008 the number of doctors, the number stood at 432. The rate of increase is something like 30-odd%. If you go back to the paper in August, the August paper, table 3 that you referred to, hang on a sec, please. What number is the paper? 2690? Yes. You refer to table 3. There is a table at the bottom there. We have the number of attendees in 2008 for A&E, and then the projected figure for 2026. Now in 2026, we projected there would be 2.72 people seeking medical treatment at the A&E. Now, if you divide this, there will be an increase of about 30%. Now, in 2007-08, they've started the emergency ward in the A&E department, so there is another component that we've added in. So from 08 to 2021, now if all the emergency wards are opened in the A&E department, we work out how many people there will be. If you take 596 divided by 434, the rate of increase is slightly higher because we have included the creation of the emergency wards. Because in 2008, there were a couple of hospitals that had emergency wards. So you haven't told us certain things in the paper, haven't you? We have the framework of the model that was presented to members, although all the detailed steps, it would be difficult to present. As the permanent secretary a moment ago, the entire computer modeling involves so many different steps for each discipline. Let's say outpatient clinics. The complex ones would involve more time, but for the same case, different doctors would devote different amount of time to it. So the entire computer model has factored in different scenarios, and we have also factored in certain margin of errors in the computing model. Let's take an A&E departments. Can you tell us the details about the adjustment? Now you said the emergency wards that have been included. Well, there is a slight increase. Yes, there is a slight increase as a result of that. Because 596 divided by 434, I've done that arithmetic. According to this rate of increase, we should be able to cope with 2.9 million people. There is a bit of discrepancy, and you have to explain to us. When I conduct a peer review, I would look at these minute details, because if they don't add up, they have to supplement with all the information. So how do you make the adjustment? In table 12, these would be fleshed out going forward, and which will include the new services for the A&E department, like you mentioned, the emergency wards, and that will make a difference to the manpower demand. And going forward, this is the way to go. And I think you have to give us all these details as well. You have to bear in mind that there is a need for manpower projection. But some people might get the feeling that you're inflating the figures in order to avoid any arguments. You should give us all these criteria to avoid any accusations of inflating the figures. And when I've looked at the table, there is a bit of discrepancy. You should tell us why there was such a discrepancy. I've got further questions myself. Perhaps I yield the floor to other members. Dr. Kwok, we'll take it in turn then. Dr. Kwok. If I may put two questions here. The first one is the psychiatric and also the general outpatient clinic for psychiatric discipline. There would be 9 to 10 minutes per consultation for outpatient service. It would be very difficult to accept. If you refer to the table, table 6 there, we understand that even for surgical discipline, it is likely that things may not be all that complicated. And you have 13 minutes here. The psychiatric discipline, and it would take an awful long time. The psychiatrists will need to and also obstetrics and gynecology, 16 minutes. Now, for psychiatric service, the doctors will go through the details with the patients and family members, the side effects of the drugs and so on. The psychiatrist will also have to look at the family life, the work life, any adjustment problem there. Now, normally, for progressive healthcare system, the U.S., Australia, we talked about Australia a moment ago, they have 1 hour devoted for new cases, follow-up consultation, no less than 30 minutes. Of course, there are discrepancies between hospitals, but applying your standard, the 7 to 9 minutes cover everything. By the time they come in, they walk in, they sit down, they keying in information into the computer, prescription, and so on. We were told that the consultation would last no more than 3 to 4 minutes. They ask them the names, the drug they've taken. By the time they're done with that, they have to leave the consultation room, and that is unfair to the patients themselves, because they do need more care and attention. At the Health Services Panel, unfortunately, we couldn't follow up on this because we didn't have chances to talk about this in detail. Now, given this situation, are you going to set the target at a more reasonable level? This is not 9 to 10 minutes is something that I cannot really accept.
Well, next, about the family medicine, your projection is that the attendances per year will be 124,000 to 13,700. And as far as I know, people have to spend 2 minutes on every patient only. How can it be acceptable to us? The administration is here and the HA representatives here. We know this is a serious problem. For the patients, it's a matter of luck where which doctor you see. Some patients will get more time, say, when the same illness is being treated. I understand that it may differ because of the training of the doctor, but for the patients, they are treated differently for the same problem. Well, if we're talking about your family members, you will find this practice unreasonable. For outpatient, can you tell me how many minutes a patient gets? That's the first question. As for the projection of manpower, all these unreasonable, unfair practices, can they be addressed? Now, for the psychiatric specialty, 9 to 10 minutes per patient. Let me give an explanation here. This is just the average figure, very rough figure. Now, of course, there is a difference between new and old cases. For new cases, 45 to an hour, and for old cases, we're talking about 9 to 10 minutes per patient. Now, we understand, and of course, you members understand that in the model, there is no quality standard of quality. It's hard to come up with a standard because we're talking about individual cases. And if we go to discuss standard of quality, first of all, we have to progress gradually. And every year, in terms of our planning, annual planning, our improvement works, we will work these out. For the manpower projection model, we will incorporate all these factors in the models. Now, at present, we haven't thrown in the quality standard, and we're simply making use of the existing models. So, whether we underestimate the manpower needed, maybe, but we will fine-tune the projection every 2-3 years. And for the time given to old and new patients, we'll give more time to new patients. In terms of family clinic, obs and gyn, psychiatric specialties, the problem you mentioned is present for all these specialties. But we should not simply look at the time given to each case, but we should rather look at the data in reality that we incorporate in the table. Well, I don't think he answered my question. You mentioned the 2-3 year fine-tuning. Yes, I appreciate that. When you project for the manpower in 2021, can you or will you have a clearer blueprint? I'm sure you find the figures, the time unreasonable and acceptable. And with what you've said, I think the projection is questionable. The manpower needed is closely hinged to the quality, however. So if you do not set a target in terms of quality, you will not get the right projection in terms of manpower. For all the projection models, you have to understand the limitations, the constraints. We cannot incorporate all the variables. As for how we can fine-tune the model, at a certain stage, if we feel that we have to give the patients more time, we can always fine-tune the model. For example, we can put in 5% more, 10% more in the relevant element in the model. Yes, that can be done, but all these elements have to be put in, have to be incorporated gradually. At present, these are not incorporated. This has to do with the constraints in the design. We cannot do it at present. As for the future, we can keep an eye on it and we can progress gradually. Do you have any target in your mind? Do you accept the 9 to 10 minutes? What is unacceptable, right? As for the right amount, it depends on the discussion of the subgroups. Well, you mentioned, I mentioned the figures, the time in Australia and US, 30 minutes at least. 30 minutes is not the time we can commit to at present in the healthcare sector, public healthcare sector. We hope we can progress gradually. We should set our targets step by step, and we will incorporate the elements gradually. But we have limitations at present. Well, I understand your difficulties, but I'm asking you for all these figures because these can help us get a better picture. And in the future, you can also cover the quality standard. As long as we have the figures, then we can come back to you for that. And I can tell you the number of doctors not enough. Some think you under-project the manpower. Well, correct, we are quite conservative. Well, my second question is about the family medicine. I want to know the figures. Well, every year the numbers 12,400 to 13,700. How many minutes does a patient get? 7 minutes on average is close to what's happening in reality. We're talking about 6-7 minutes in reality at present. We're giving them enough time for consultation is right. Each doctor only see 1/6 of the patient projected. When can you address this problem? That is to make the figure in outpatient align with the family medicine specialty. Well, we have to look into it in the future. Next, Mr. Peter Cheng. I'm a layman. I don't quite understand the tables, especially the columns. Just now, Dr. K.K. Kwok mentioned all these problems. can you put down something that meets our expectation? Say, for example, table 6, which is about the psychiatric specialty, 9 to 10 minutes per patient. In overseas, 45 or 30 minutes for each patient. Can we upgrade our time to 10-15 minutes? And then you can use this to project the manpower. I'm not saying that we have to meet this target by 2016, but at least we find 10-15 minutes acceptable. And based on that, you can increase the manpower by 50%. And you will know you are 150 doctors less. We're not talking about a shortage of doctors. It's just that you do not have a lot of doctors studying psychiatry. So can you upgrade the benefits so people will be willing to study psychiatrics? You have to work your way through this way. Say, for example, how can you encourage people to study this specialty? Now, let's put aside ideal. Let's talk about acceptable time. 30 minutes, 45 minutes per patient may be not exactly practical, but can we set it down to 10-15 minutes? If you find it acceptable, you have to work out the process, how we can achieve this target. I understand that you are being practical in your projection. Say, for example, you put down 9-10 minutes per patient. In reality, some leave the consultation room after 5 minutes, but I'll take your word for it. Still, with the same consultation time, the service does not see any improvement, even though you have done a lot. You have to give the impression that users think you have some sort of improvement. That's why you need some targets. I don't think it's hard for you to put down the targets in the table. Chairman, can I ask him to explain the table in 1 to 2 minutes? Well, yes, but for our subcommittee, when we talk about the manpower projection and how the HA conducts its researches, it really affects the manpower projection. And once the HPS is rolled out, the manpower will be affected in a grave manner. What did you ask him to do? To set down one more column. You mean about the target? Yes. And can he just explain the tables in 1 to 2 minutes so I can understand it better? Yes. Well, we have time. Perhaps you could give it a try. First of all, about the expectation, about the targets, can you put it down in the table? I'm sure you can do that without the figures. We build the table on a certain basis. It's not hard for us to make adjustment. Say, for example, you have to set down the consultation time to 15 minutes for outpatient. We can simply inflate the figure with the basis. Yes, we can do that. But can we set down the targets? I don't think we have reached the appropriate stage. Because we need to have a discussion with the specialty. It's not up to the HA to say so. Say, for example, 10% increase. We have to have meeting with different subgroups, different specialty to see which area is most undesirable and which resources should be put in which areas, and how much resources is to be increased, say, for example, in terms of percentage to keep it up with the increase of users. Now, we haven't reached this stage yet. we had lengthy discussions with the specialty in coming up with all these tables. For example, we spent a lot of time discussing the manpower needed and the time needed. We will incorporate all these elements gradually, but not at present. We can't do this now. I'll defer to Ms. Choi to explain the tables to members. Let's pick a table, the psychiatric specialty table, table 6 then. For the psychiatric specialty, we in fact had a meeting group together with different specialists. They provide the parameters to us, and we're talking about more or less the same parameters. Say, for example, the doctors. We have inpatient care, ambulatory, community care, and others. Let's focus on inpatient care. How did we come up with the time for inpatient care? We set down the working hours from 9 to 5. Say, for example, for psychiatric specialty, we come up with the average number of cases. But of course, you understand that the complexity varies. And for inpatient day patient admission, the average time is 38 to 41 minutes. For daytime, 2016, we're talking about 32,000 inpatient cases. So we need 20,000 to 22,000 per year in terms of doctor hours. As for inpatient bed days occupied, now the doctors have to do round. They do 2 rounds, one in morning, the other in evening. For psychiatric, that's for the general doctors, but for psychiatrists, it's quite different. For the acute cases, they have to do rounds every day, but for the non-acute cases, they may not do rounds so often. Still, we base the figure on the bed days occupied. For the average minutes per bed day on ward round, that's 9 to 10 minutes. A times B means the doctor hours. Now, the doctor have to do other services in the daytime. For medicine, surgical specialty, they have cross-specialty consultation. The parameters put in were taken from certain hospitals, say the quarterly data, for example. And that will amount to A1 to A2 plus 80%. And then we look at the on-call hours. That is after 5 p.m. to at 9 a.m. in the morning.
They have 15 to 16 hours of on-call hours, and they have 1 or 2 doctors on hand for on-call service. So for 365 days per year, there will be 15 to 16 hours per day. They may have 1 or 2 doctors on call. That's for inpatient care. For ambulatory and community care, we average out the figure. Outpatient psychiatric, the new cases take up 4% of the caseload. So we have 40 to 60 minutes for each consultation, and they take up 4% of the total caseload. So together with the community care, it is 9 to 10 minutes per attendance or per visit. In 2016, we're talking about 1.2 million attendance. The last one is other service. One of the functions of the doctors is the training of specialists. They need to do mentoring. They need to engage in administration for pediatrics and so on. They do spend time communicating with the family members, and they have to put in the clinical record into the computer. We factor in the time, and that is about 20% of the total doctor hours. So all these taken together in 2016, we project that we need 550,000 doctor hours. And for psychiatrists, each year, doctors' working hours, discounting the rest day and public holidays, and sick leave, study leave, and so on, roughly they work 1,600 to 1,900 hours. So D divided by E, that is the number of doctors. The changes in the amount of service will make difference to the number of doctors required. As members said earlier on, we discussed these parameters with the committees. We have the baseline year 2008 to work out the reliability of the parameters. So this is the baseline scenario, and we can work out another scenario with more higher quality service parameters, and the number of doctors will be greater than what is presented in the paper. Any follow-up? Right, let me follow up myself. There are 2 points here. Let's take this psychiatric. You said outreach, community care, new cases, old cases, they're lumped together in the same table. Internally, I suppose you have to break down, so you're just giving us the average figure, or is it the case that you lump them all together as well in the internal system? Well, we do have the indicative figures. These are projections, and they cannot be entirely accurate. They are subject to certain constraints, and we do build in certain assumptions there. At different years, we have a different level of projected manpower. There is a margin of error that has to be accepted. There are figures for reference. Well, this is not what I'm asking. I'm asking you, I fully appreciate the constraints involved in projections and also the margin of error. I'm talking about a methodology. Now let's take outpatient service. Now the methodology, community service and outpatient, you have put the old cases and new cases together, and you take an average of 9 to 10 minutes. Internally, do you have the breakdowns, or is it the case you lump them all together in the internal computation? Well, we do have the figures. Now let's say 4% of them are new cases. So the new cases are 4%, and this doesn't make any difference to the average. So we're talking about some percentage deviation here. Well, in terms of percentage, you have the breakdowns between the two. So when you work out the details, you don't use the indicative figures. Yes. We ascertain whether the indicative figures would make a difference to the ultimate sum. If it is not, it will not, then we disregard the figure. Or would you just take an average? Well, we cannot go into the fine detail. I'm asking you the methodology. You have the indicative figure. Now, if you split up the figure, then it doesn't make any difference, then you don't split up the figures. Is that right? Yes, for individual cases. Yeah, I'm talking about the individual cases. If it does make a difference, then you split them up. Is that right? If there is no difference, then you lump them all together. That's an individual case. Yes, more or less like this. Well, these are the raw data. If the raw data are not adopted for computation, now the 4% doesn't make any difference, and you lump them all together. And if the raw data don't make any difference to the computation, it should be fine. But if they would make a difference, please let us know, because we get some ideas from that. If you break the figures down, A1, A2, A3, A4, you can have A5 through to A8, and if you have these breakdowns internally, show us, please. If you don't have the breakdowns for internal computation, fine. We take it at that. We leave it at that. Here you're giving us the range. Now that has to do with the margin of error. When you look at the figures, we take a mean or we take a median to work out the median figure or the average figure. But because of the margin of error, statistically, we would use the standard deviation, or we use the range to show the variation or the margin of error. Here, we are given the range. With this range, it would be rather difficult for us to have the single solid figure in table 2. Well, you can work it out by using the median. Can you give us an update, please? All medical journals are like this. When data are presented, there must be a figure showing the central tendency. The most commonly used is the mean or the median. This is the central tendency. Or they have the spread. Now, the most commonly used would be the standard deviation, or the interquartile range, or just the range. All medical journals would have this kind of data. Otherwise, you would not pass. You want to score a pass in your medical journal. So either you have the median or the mean, or the range or the standard deviation. Well, we take a mean, and the we don't use the standard interval. We don't make it so complicated. Now 5%. If you want to have the figure computed, then you can work it out just with the mean. Well, here we're given the range. Why don't you give us the mean as well? You have the figures in hand already. Why don't you present the full picture? Right, let's say 3,564. We have to qualify all this range and the margin of error and so on. In your range, you have the margin of error, you have the standard deviation, and you can tell us the margin of error with mean. Today's mean would be different to tomorrow's mean, and the mean for the day after tomorrow. So if you give us a single number, it would be the average for that prevailing period. That's why we need the standard deviation. That's why we need the range. That should be okay, wouldn't it? Right, psychiatric specialty. Each doctor works 1650 and 1900 hours. If you divide it by 5 weeks, each week they work 38 hours, discounting the meal break and the holidays. Right, I know that. 52 weeks in a year, 17 statutory holidays, 67 days, and sick leave, study leave have to be factored in as well. Let's say, well, I'm very familiar with the public holidays. 52 weeks divided by 42 weeks, or let's say 42 weeks. 1900 divided by 42. Each week they work 45 hours, including the holidays and so on. I'm sure when you do the manpower projection, now in the private sector, doctors are working for themselves, and the more they work, the more pay they get. If there is a service demand, they can work exceedingly long hours without being restricted to 45 hours per week. This mechanism would avoid manpower shortage. Now they're working 1,900 hours. Orthopedics, 2,400 hours. Much longer. Of course, there is some historical reason for that. Now let me put this to you. At the hospital authority, when you project the healthcare manpower, overtime work, a system where they get paid for more work, that can really mitigate the manpower shortage. The lowest is 1,650. If we have a more pay for more work mechanism, you can release a lot more manpower going forward. Now, how would you address this particular problem? Well, I think you've hit the nail in the head. That's why in our computer modeling it is so complicated and so difficult. We have split up the public care and the private care. In private care, the doctors work long hours for better pay, but in the public sector, some of the doctors are in semi-retirement or they're close to retirement. In the public sector, if we adopt this mechanism that is adopted in the private sector, if they work overtime, then you pay them for the overtime, and that has to do with the policy matters. First of all, the maximum capacity would be subject to a limit. So we have regard to the quality of life, the capacity to handle the situation, and so on. In the near term, you may be able to do it through this mechanism, but in the long term, we do have policy consideration.
Now, this is a short-term issue we're facing. As for long-term planning, can we rely on this approach? It needs some consideration. Yes, we're aware of the problems you mentioned, but please appreciate the complexity. That's why we spend so much time in looking at all these different sorts of factors and assumptions. All right, understand. Well, this may be a policy issue, whether more pay for more work is feasible. Yes, can we do that in the long run? Apart from manpower projection, which is the first step, we also have to consider the margin of errors. The second step, after projection, is to come up with a measure to look at the margin of error. Well, I think it's best for you to shorten the adjustment period the best you can. Say, for example, you can only throw in more manpower in the coming 10, 15 years. That would be too late. You are actually lagging behind the demand. So can you, in fact, shorten the adjustment period the best you can? Chairman. Yes, you got the point that we are actually considering. Why we come up with the projection, manpower projection for the short run, which covers the public and private sector. Because, first of all, the private sector amounts for 90% of the market. Is a large share. So the model covers both sector. And we are working on the models, on the projections, and the projections cannot last forever. That's why we refine the projections every year. And we're also looking at the demand in the next 10, 20 decades and the problems that's going to arise in 3, 5 years down the road. We have also to look at what the HA is doing. For example, some doctors go to work on a part-time basis. These are measures to address the problems in the short run. But how many extra hours can they work? Can they do it in the long run? We have to give some deliberation. If there is a peak in the short run, what are we to do? And if we have an excess manpower, what are we supposed to do in the long run? We can always give more allowance to doctors in the short run. And you cannot ask the doctors to work on a certain mode forever. So we see whether the licensing exam can address the problems, for example, the problem of excessive manpower in the short run. Well, the long-term measure will have to do with the training of doctors. All in all, we have to take into account the demand side. For example, the aging population. How is it going to affect the demand side? We also have to look at the supply side, that is, of the supply of manpower. We also have to look at the resources, the money, the manpower. Even if we have the resources to provide training, do we have the qualified candidates to receive such training? Do the two universities, can they get the resources to provide training for so many intakes? Well, even the medical schools say that they cannot expand the intakes and train so many doctors in a certain period. And we also have to look at the quality of the new recruits. To put it simply, it's a complex issue. In the society, we have flexibility. There are indicators showing when you have to put in more manpower and when you can stop such increase. One of the ways to go about, if you have questions, please raise your hand. Otherwise, I'll go on. Yes, I'll give the floor to you now. You go first, Chairman. Okay. Now, for all these mechanisms, you may have your views, but the most important thing is for you to make it public so we know whether it's feasible and how it's going to be operated. For example, the increase of intake of medical students. Now, if you simply look at the needs of HA and there is no more work, more pay approach here, I see a problem in this. Because without this approach, many doctors leave the public sector to go to the private sector. And there is excessive supply in the private sector. So in the future, I hope you will see more suggestions so that the the mechanism, we see equilibrium manpower in both public and private sectors. With excessive manpower, it's not going to be good because you waste valuable resources. Another area that you might like to consider is if you cannot recruit permanent staff, you will go for part-time or contract staff. There's a certain percentage of 5 to 10% of such staff. Let's say you have this percentage for contract staff, part-time staff. Let's say it reaches 10%. It should be an indicator showing a shortfall of manpower. That means you need to recruit more permanent staff. And with that, it's easier for management. If the part-time percentage falls to 1%, it means that you do not have lots of vacancies in HA. Then you can cut down on manpower on staff. This is one of the ways, one of the easier ways for you to adjust the manpower. If the market is not good in the private market, more people will come to the public market to do part-time jobs for you. Well, at the end of the day, you have to set up a sort of mechanism and to shorten the adjustment period. Let me answer the questions. In fact, you have pointed out what we are doing now. And the model is there for us to project the demand in the coming years. That is the long-term, short-term situation. And we will accordingly come up with options to address, say, for example, short-term problems. So we're actually adopting the approach you're proposing. Dr. Chang, apart from looking at manpower demand in the short run, or long run, we also have to look at the short run. Say, for example, we have a insufficient supply in A&E ward. We have more work, more pay approach mechanism. For example, some doctors are willing to take on shifts on the weekends or public holidays. We give them more. This is the more work, more pay approach. This is a contingency measure. And if we continue with this approach, how many more cases we can take up? That takes time to look at. But we have to see how well this approach is received. Well, doctors join on voluntary basis, and we also have to look at the expertise of the candidates. As for opening up the specialty, we're still looking at it, considering what's the current effect. We can come back to you on the 18th of March. Yes. Well, Dr. Chang is right. In terms of management, we also have to look at the cap. Because we don't want doctors to take up part-time job in the long run. If a doctor can afford to spare time to help out, there is a mechanism for them, say, for example, how many extra hours they can put in per month. But if it's a long-term measure, that may affect the doctor. I'm simply looking at the average figure or the mean. Well, for the working hours per doctor, you give out the figure of 1,650 to 1,900 hours. And if you're 10% behind target in manpower, using these circumstances, then you can raise the working hours up to 2,100 hours. But of course, we know the doctors in that specialty are already having a hard time. Well, you can simply solve the problem by raising the annual working hours from 1,900 to 2,100 hours. But you cannot really solve this problem. In essence, will we encourage doctors to work an extra 24 hours when they're working 45, 44 hours already? Will we do that? Well, Hong Kong people are very hardworking. If it's on voluntary basis, then you can ask them to work for 48 hours. Well, the A&E ward is on trial at present, where this approach is on trial. Now, after the HPS is launched, what implications are there on the market? I think there will be a fall in demand of services in the public market. Don't hesitate. The projection does not take into account the HPS, is that right? I see you're nodding. It's a dynamic model. It's not about statistics. You see, the demand is rising. We're talking about 20% increase per year. But the HA has not taken into account the HPS, and it has already taken into account the aging population. And in the future, you will add the quality service indicator. Well, that's why I say it's very complicated, and we have to consider a number of factors. I'm just reminding you that the HPS will have implication on manpower in both public and private markets. I think it will relieve the demand in the public market. Otherwise, there is no urgency for you to roll out the PHS. You keep saying the HPS is there to relieve the pressure on the public market. So there should be some implication on the manpower there. Dr. Kwok K, we understand that you may not have meetings very often, but I think the information in the papers are really rough. For the different disciplines, I'm sure they have their own ideas about their targets, about the manpower they need. But for all these figures, for all this information, it's not included in the paper. I hope you can come back and add this information. You say that at the end of this year, you will have a conclusion.
Second, this is directed at the administration. It may not have anything to do with the hospital authority. Occupational therapists and physiotherapists, the demand is not restricted to hospitals. At Ophix homes, for instance, the hostels for the physically handicapped, they are really desperately looking for the right manpower. For hostels, for the intellectually impaired, they don't really have any physiotherapists, occupational therapists. 1,500 for occupational therapists, 1,200 for physiotherapists. They're working for the hospital authority, DH, in private sector or NGOs. As we are aware, the administration takes the aging population very seriously, and Mrs. Carrie Lam is involved in the committee, the steering committee on population, also nurses. Each qualified board plates residential homes of the elderly, there is a need for nurses. We did talk about this at the long-term care subcommittee. I look forward to a paper in this regard. Now for the therapists, occupational and physiotherapists, I hope that there would be further papers coming along regarding the projection. Doctors, 13,006 TCM. The number stands at 8,300. Now, it is different from other areas. In other jurisdictions, like Australia and so on, now they have an index, and Japan also, they don't really have any TCM practitioners. But TCMs do take up a certain proportion for primary health care. So when you project the number of doctors, have you taken into consideration the TCMs? It doesn't have any implications on other specialties, but for family medicine, there is a bit of overlapping between GPs and TCMs. Now, if you increase the number of TCM practitioners, then the number of GPs will be less than what you project. The TCM practitioners are produced by the universities, and there is an assurance of quality, and they will take up a different role than that in the past. Do you have any correlation between the two in terms of TCM practitioners and GPs? I mean, they would be able to work for their disciplines. Mr. Yin. Dr. Kwok asked this question about the complex modeling. Now we are engaging the Hong Kong U to look at the manpower. We simply cannot just look at the private sector with aging population. We have to look at the old folks' homes. Now with middle class people getting old, they may need home care. They need more nurses. So we're not simply look at this aspect alone. Now we are also concerned about the old folks' homes. Dr. Chen, Professor Chen, is chairing that committee, so we can rest assured. We have also taken into account the requirements of nurses as a result of the aging population, the demand for nurses in hospital setting, and also our RCHEs. You mentioned also the TCM practitioners and GPs. When we do the projection, as I said, one of the factors we take into account is the substitutability between the different disciplines. Now, in primary care, the TCM practitioners do play a pretty significant role. And we have to look at the manpower level as well. And that's why the whole modeling is so complicated. It is a comprehensive, scientific modeling. And we cannot replicate the same system from overseas jurisdictions simply because of this. And there are circumstances unique to Hong Kong. So in a month or two's time, we can come and present the model to members. I don't think members should pin too high an expectation, because the modeling is terribly complicated. We'd like to take this first step in coming with a model, and this represents a good start. Going forward, we will, depending on the circumstances, refine the modeling so that we have a more advanced, comprehensive model that can project the medical manpower for us. It would take a certain number of years for this to be coming to fruition. Dr. Kwok, when the steering committee had 2 rounds of meetings, do you have any statistics that can be made available to this committee? Mr. Yun, Chairman, I'm afraid not. With these forecasting models, we need to have all the parameters agreed upon. If we have agreed upon the factors, it would be easier for us to come up with the statistics. So all the assumptions have to be agreed on. We are liaising with the universities at the present moment. So when we present the situation, we are presenting the assumptions, how the figures are captured, like Dr. Kwok said, the RCHEs, the demand for professionals and so on. And we'll have to have the fundamentals of the model in place before we input the data. Then the computer would take it from there. Chairman, you asked us what factors to be taken into account and what not. I mean, that is a complicated thing. Any further questions? If not, we don't have to end the meeting at 1:45. The next meeting is supposed to be the 22nd of April, but if an administration is not quite ready, please give us a shout. We can delay the meeting. The regulation of the insurance, the latest details and so on, let the Secretariat know. I mean, unless there is anything further, I adjourn the meeting. Thank you all very much.